Hello friend, welcome to my channel 5 Minute Pediatric. Today I will be discuss about the treatment of Kawasaki in children. So before going to treatment, first of all we have to identify the condition. So I have made mnemonics for identification. The mnemonics is a free class in AC. So F for fever more than 5 days, R rash should be polymorphic, E for edema of foot and hand, E for erythema of sole and palm, C for conjunctival congestion at the bulbar region, L for lymphadenopathy. So cervical lymph node should be enlarged more than 1.5 centimeter and should be unilateral. SS means strawberry tongue, should be associated with cracked lip. IN for IVIG, the dose is given at the dose is 2 gram per kg. A for aspirin, the dose is 80 to 100 milligram per kg per day until afebrile for 48 hours, followed by 3 to 5 milligram per kg per day if there is no coronary abnormality during the course. C for clopidogrel if coronary abnormality is present. So the treatment of Kawasaki is divided into two stages. So in acute stage, IVIG is given. Dose is 2 gram per kg over 10 to 12 hours. And aspirin, the dose is initially given at a dose of 80 to 100 milligram per kg per day, divided every 6 hourly orally until the patient is afebrile for at least 48 hours. In convalescent stage, the dose of aspirin is 3 to 5 milligram once daily orally until 6 to 8 weeks after illness onset. If normal coronary finding throughout the disease. Now, if there is a coronary abnormality, so what long-term therapy we should give to the patient? So it is recommended that if the patient has a solitary small aneurysm, then aspirin should be given for indefinite period. Decision about inclusion of additional antiplatelet medication or anticoagulant for patient with larger numerous aneurysm should be decided in conjunction with pediatric cardiologist. So the dose of aspirin is 3 to 5 milligram once per day, and clopidogrel is given at a dose of 1 milligram per day. The maximum dose is 75 milligram per day. Most expert add warfarin or low molecular weight heparin for patient who having particularly high risk of thrombosis. So if a patient develop acute coronary thrombosis, so it should be promptly treated with thrombolytic therapy like a tissue plasminogen activator or another thrombolytic drug in pediatric cardiologist supervision. And the complication, so the patient with coronary aneurysm should receive long-term follow-up that include routine echocardiography, stress testing, and maybe angiography if there are significant aneurysm present. For the treatment of coronary stenosis caused by Kawasaki disease, cardiac catheterization has been utilized along with direct coronary arterectomy and stent insertion, and some patients may require CABG. To lower risk of Ray's syndrome in patients with long-term aspirin therapy, influenza vaccine should be given every year. During the 6 week following varicella vaccination, aspirin should be replaced with another antiplatelet medication. Measles, mumps, rubella, and varicella vaccinations should typically deferred until 11 months after IVIG administration because IVIG may interfere with the immune response to low virus vaccine because of a specific antiviral antibody. Kill vaccine should not be delayed in case. So now 15% of Kawasaki disease may develop IVIG resistant, and this can be indicated by persistent or relapsing fever 36 hours after initial IVIG injection. So these patients are likely to develop coronary artery aneurysm. So these patients required additional dose of immunoglobulin IVIG 2 gram per kg per day. Some cardiologists may also add corticosteroid as a disc therapy